Welcome. In this explainer, we're going to break down a really critical clinical decision: how to figure out what's going on with an acute joint injury, and, more importantly, what to do about it. So, let's jump right in. Okay, so let's set the scene. A patient comes in with an acute joint injury. Now, you have to figure out what you're dealing with. Is it a distortion, a subluxation, or a full-blown dislocation? Getting this right from the get-go is absolutely fundamental because it changes everything about how you're going to manage that patient. To really answer that question, you need to think about these injuries as being on a spectrum. It's not three totally separate things, but more of a continuum of increasing damage and, increasing joint instability. It all starts with a sprain and goes all the way up to a complete separation. All right, so let's start at the mildest end of things with a distorsion, which you probably know better as a sprain. What's happening here is the ligaments and the joint capsule, they get stretched or maybe even partially torn. But, and this is the key point, the actual surfaces of the joint, the articular surfaces, they haven't lost contact. The joint is still fundamentally stable. Okay, moving up that spectrum, we get to subluxation. Think of this as a partial dislocation. The joint surfaces definitely lose their normal alignment, but unlike a full dislocation, there's still some contact between them. What's really interesting here is that these can sometimes pop back into place all on their own. And that brings us to the most severe end of the scale, a true dislocation. The definition here is really precise. It's a complete separation of the joint surfaces. And, this is super important, it's a lasting separation. Those bones are not in contact at all, and they are not going back into place without you doing a specific reduction maneuver. Now this table, this really just crystallizes the whole concept beautifully. Just look at that last column, articular surface contact. It really does all come down to the degree of separation. For a sprain, contact is maintained. For a subluxation, it's a partial or maybe temporary loss. And for a dislocation, it's a complete and persistent loss of contact. That right there, that's your diagnostic pivot point. So let's focus specifically on dislocation for a minute. We're singling this one out for a very good reason. It's a genuine clinical emergency. The clock is ticking, and its management is absolutely the most time-sensitive. So here's what you have to get. A dislocation is so much more than just a bone being in the wrong place. It's an emergency because of what's happening to all the structures around the joint. Think about an anterior shoulder dislocation stretching the axillary nerve, or a knee dislocation that could compromise the popliteal artery. These are absolutely limb-threatening risks. And on top of that, you've always got to be thinking, could there be a fracture in there too? Because that makes it a much more complex fracture dislocation. So you can see how understanding these distinctions directly shapes what we do next. It's simple, really. You can't treat what you haven't correctly diagnosed. That diagnosis is what drives every single thing that follows. And this slide basically lays out your playbook. The diagnosis dictates the intervention. For dislocations, speed is everything. You need a rapid reduction to take the pressure off those nerves and blood vessels. For sprains, you can usually take a more conservative route. But look at that third one, intra-articular fractures. For those, the goal is nothing less than a perfect anatomical reduction, and that usually means surgery, because you have to restore that joint surface perfectly to prevent long-term arthritis. Your initial call determines which of these paths you're going to go down. And this is a hugely critical point of practice. Don't even think about trying to reduce a major joint, like a shoulder or a hip, without getting the patient proper anesthesia and muscle relaxation. It's just not the standard of care. The patient's pain and muscle spasms are going to fight you the entire time, and you're just going to increase the risk of causing more damage. Okay, let's wrap this up and summarize the most important points. What are the things you absolutely have to walk away remembering? When it all boils down, your number one job in that initial assessment is to answer one fundamental question. Is this injury stable or is it unstable? Is this something that can be managed conservatively, or is it something that needs immediate, definitive action to get things aligned and prevent bigger problems down the road? That's it. That's the pivot point for everything else you do. So I'll leave you with this final thought. Next time you see a major dislocation, I want you to ask yourself, what is that clock really ticking against? It's not just about pain, right? It's about irreversible damage to tissues. And truly understanding that urgency is what makes all the difference.